Thank you for attending this webinar this afternoon. I'll be chairing the session this afternoon. My name is Ashley James. I'm the Director of Practice and Development here at the Chartered Society of Physiotherapy. We have two brilliant talks and brilliant speakers and an excellent panel to work through some questions towards the end. Just to run through who is going to be presenting and who is on the panels. As I said, I'm Ash James, the Director of Practice and Development. I'll be chairing. Our speakers are David Long, who is from the FitNote policy team at the Department for Work and Pensions. We have Abby Henderson from the CSP, who's currently our head of practice. And on the panel, we have obviously Abby and David, so the CSP and the Department for Work and Pensions. We also have Laura Groom, who is an advanced MSK practitioner and is part of the APPN, the Advanced Physiotherapy Practice Network. Alongside Laura, we also have Michelle Angus, who is a consultant physiotherapist and vice chair of the APPN. So it's brilliant to have the APPN on board. We have Matt Daly, who is an advanced practitioner, an upper limb specialist and an MSK sonographer. He's an FCP clinical lead and is from the MACP and is their communications officer. We have Paul Shawcross, who is a physiotherapy lecturer, placement lead and webinar coordinator for ACPOHE, so the Association of Chartered Physiotherapists in Occupational Health and Ergonomics. And we have Pam Simpson, who is the honorary communications officer from Physio First. So we have a really broad, experienced, excellent panel to take us through the proceedings this afternoon. So welcome to all the speakers and welcome to all of the participants. Before we get into the talks, I wanted to relay some data to you, because I know you were all kind enough to give your opinion and answer some questions when you registered for the webinar, and I thought it'd be really useful to feed that back. And then we've got a couple of polls before we get started. So you were asked a series of questions before joining, and we've had a really good response to those. So the first question was, before seeing this webinar advertised, were you aware that legislation had changed that allows physiotherapists to certify fit notes? 431 people answered yes, 56 people answered no. So that's great and gives you a sense for how many people have interacted with this webinar, which is excellent. Have you completed the FitNote training on e-learning for health? 138 yes, 337 no, 12 not sure. Have you accessed the DWP FitNote guidance for healthcare professionals? 185 yes, 302 no. Have you accessed the CSP Fitness for Work web pages? 208 yes, 279 no, so a bit of a split there. Have you undertaken other training relating to FitNotes? 96 yes, 391 no. Have you certified any FitNotes to date? 60 yes, 427 no. And the key question at the end, I think, which is really encouraging and great news, is, do you think you'll certify FitNotes in the future? 308 yes, 15 no, and 164 not sure. So hopefully this webinar can bring some clarity to some of those uncertainties that some people maybe have. So I just thought it's really useful to share that information. Now, before I go into the polls, and we're going to put some polls on some further questions for you to answer, just a reminder that the Q&A function is there for questions. Please do utilize it throughout, and I will put your questions to the panel after the two talks have happened. And also do note you can upvote certain questions. So if someone has asked a question that you were going to ask, if you upvote their question, it'll move further to the top and it's more likely to be seen and answered. So just a note of that function there. So just for some more information, if we could share the first poll, please, May, that would be excellent. So this is just about where people are in the country. Give ourselves 10, 20 seconds to answer that. Okay.
Yeah.
Perfect. So do we see the results of that? There we go. So majority from England, some from Northern Ireland, some from Scotland, and some from Wales. So welcome to everyone from all four countries. It's excellent to have you here. Brilliant. And the next one. And before you rush in to answer this poll, there's just some context I want to give the private practice in occupational health, because you may well be a private practitioner working in occupational health. If your predominant role is occupational health and that's the environment that you work in, please answer occupational health. We want to get a good sense of where people's specific role is around occupational health. So just a bit of context there. But other than that, please answer away. Another 5-10 seconds and we should be good with that one. Excellent. Well, that's brilliant. That's a really, really nice split between sectors and demonstrates, you know, where and how we are influencing work and health. So that's a really, really good picture from my perspective to see. So again, welcome to everybody. So I'm going to hand over to David first. And as I said before, David Long is from the Department of Work and Pensions, and he is the FitNote policy lead in the policy team there. So brilliant to have David on board with us. And I know we've worked really closely with the DWP in the development of this. So it's brilliant to hear from David. Over to you.
Thank you, Ash. So I'm gonna speak for just the first part of this, and what I'm going to try and cover is a little bit of background from a government and policy perspective into the reasons behind the change. I'm also going to cover a little bit of the detail for how we got to this point and talk a little bit about the legislation, although I'll try and do that in a way that doesn't bore you. And then I'll basically hand over to Abby at that point for the rest of the slide, for the rest of the presentation. But the starting point for this really was not so focused on the FitNote, but was part of a large government agenda around work and health. I think particularly over the last decade, there's been much greater recognition, which has been coupled by research and evidence around the importance of the links between work and health. And given that adults spend so much time and so much of their lives in work, the impact that has on their overall health and the impact their health has on work and the kind of cycle that's involved there is much more important. And where that gets drawn into clinical practice and clinical conversations has been very much developing, particularly because there is clear evidence that having good work improves health and well-being more broadly for people, which has that kind of cyclical effect. Now, in government terms, this was always kind of there, and there's been consultations and publications that have looked at this and looked at how we update our approach to recognise this. But this has kind of it's had a real spotlight shone on it because of COVID-19. And I think that really highlighted for government, particularly the importance of work and health and the kind of emerging recovery from the pandemic and how we're looking to essentially build back better and boost economic growth and support people with health conditions is really at the forefront of some of the work that we do. I think where I work, so whilst I am Department for Work and Pensions, I actually work within a joint work and health unit that sits between the Department for Health and Department for Work and Pensions. So there is a kind of dual focus on this where we are looking at both sides of it, both the kind of employment and the economy and those factors, but also the healthcare sector and how that kind of dovetails in. And I think that recognition of the links between work and health and just how important that is really at the forefront of certainly the work that I'm involved in delivering, and one of the key drivers behind the work to look at FitNote specifically. But it is worth noting that the FitNote and the stuff that sits around that is one small part of this, and actually the greater emphasis is overall on recognition of work and health and how important that is. And there are some really stark statistics that kind of paint a picture for how important this is and why we recognise it as important. A couple of these are quite dramatic, so I will just rattle these off. But there is some evidence that suggests that after 5 weeks, just 5 weeks off from work, individuals are as likely to not return to work as they are to return to work. So it's about a 50-50 split as to whether they'll return to work or not after just 5 weeks off from work. If you then extend that to 6 months off work, this drops dramatically to only around 20% of people returning to work, or a likelihood of around 20% of people return to work. So that means after 6 months off work, a person is more likely to be diagnosed with cancer than they are to return to work after an extended period of sickness. And if you roll that further even forward, once a person has been off work for 2 years, they're statistically more likely to die than they are to return to work at that point. And I think that really builds the kind of picture for why early intervention and the specific role that individual professions can play is really important, and why we have really driven forward this work with FitNotes. If you can move on a slide. There's been a lot of collaborative work around this, and that extends beyond government. So there was a consensus statement around work and health that was done alongside of medical colleges and professional bodies in 2019. And to support that, and one of the actual prerequisites for the training that was launched around the FitNote was a suite of products on HE's eLearning for Health hub in recognition of that. So there's a kind of core offer that looks at upskilling people and making them more knowledgeable and aware around work and health more broadly. And again, that kind of sits above and around this and feeds into the work that's been done on the FitNote. If we move on another slide. So where this then actually comes to the FitNote specifically is that we have a very specific kind of policy aim around the FitNote, which is essentially to help facilitate better work and health conversations, with the ultimate goal being that it supports people to manage their health conditions and stay in work. Just as a kind of brief background for people who aren't familiar with FitNote or know what it's used for, the FitNote, which was previously called the Sick Note, and I think often is still referred to as that, or Med3 form, is essentially a statement of someone's fitness for work. And it's used as a record of a conversation about the impact a person's health condition has on their ability to work. And it, as of 2010, when it was changed to the FitNote, it now includes an option to say someone is maybe fit for work, taking into account certain advice and conditions and workplace adjustments, whereas previously it was a very binary, you're either sick or you're not sick. The FitNote is really important. It's the most readily available source of medical evidence that's free at the point of delivery through the NHS. And there are a significant number of them produced each year. So in general practice alone, the published data that we get on this tells us that just in England, in general practice, there's around 10 million of these issued a year. And what they're used for is to provide evidence of eligibility for statutory sick pay, so for those in employment, or to give people access to health-related benefit support from Department for Work and Pensions. Of those two main uses, most of the FitNotes that are in circulation end up with employers. So we think the split is around 80% used for people in employment, and the remainder then basically are used within the benefit system. But hopefully that paints a picture for why there is so much focus and importance placed on the FitNote, is because they basically give eligibility and access to really significant things that have wider impacts on both employers and the economy, but also fiscal spending for government under DWP benefits. The ambition that's up there on the screen was what we set in 2017. So there was a large body of work behind this, and the aim really was to go beyond just tinkering with the system and making improvements, but actually wholesale trying to do a broader body of work around improving work and health conversations overall, which is what I mentioned before, with the FitNote being part of that. The main focus following the consultation in 2017 and the commitment made was to look at recognizing a more multidisciplinary workforce that has developed within health, and to reflect that there are more professions that are possibly as well, if not better placed than doctors to be able to sign and issue FitNotes. And previously, and this is worth noting, since medical evidence existed, so since it was written into law, which goes all the way back to the creation of the NHS in 1948, medical evidence certification of this nature has always sat with doctors. And this year is the first time we've managed to move away from that. So if we could move on to the next slide. So this year we made what was for us quite a significant change, and we delivered legislation in July that was enacted on the 1st of July that legally enabled basically a broader group of professions to issue certified issue fit notes beyond doctors. So we added 4 more professions to the regulations, and those were ones on the screen: nurses, occupational therapists, pharmacists, and physiotherapists, in addition to doctors. So doctors can still do it. Prior to this, in April, we actually made another legislative change to update the process for issuing fit notes. And as I'll come on to in a minute, basically some of the legislation that, and I don't know how familiar people are with working with government legislation, but some of it is relatively old and outdated because of where the primary powers come from. And as a result, the process for issuing a fit note was still relatively archaic, and it involved a requirement that fit notes actually had to be completed and signed in ink to be legally valid, which means they had to carry essentially a wet signature. So we changed the regulations initially in April to remove that requirement so that fit notes can now be certified, completed, and issued fully from digital systems where that's possible. And then we've been working since to actually get that landed within relevant IT systems across healthcare settings. Now, the work behind this, and I think it is worth being really candid and recognizing that we understand, particularly from an external perspective, that government appears to move very slow on this. The original intent around this was set in 2017, and it has taken this long, so essentially 5 years, to actually deliver the legislation. Now, the reasons for that are that we have to work across a range of stakeholders, which includes the devolved administrations, because the legislation is GB wide, and have to agree it across the various regulators' professions, both within healthcare, but also in regards to benefits and employer representative groups as well, to agree a policy approach. We originally addressed this from a properly multidisciplinary perspective, and we tried to find a way in law to identify that essentially anyone with the prerequisite kind of learning skills and competency could do this. So very much in keeping with the direction of movement with things like the advanced clinical practice framework and things like that. But essentially, because we're working with DWP legislation, that simply wasn't possible from a legal perspective. So after a lot of work, which involved a broad range of stakeholders, and quite a few of those from a health perspective, which included CSP, and they were actually really instrumental in working with us to help get this over the line. What we came to was a solution that was essentially adding more professions to the list that existed in legislation. And that's how we got to this now list of 5 professions. This obviously had to be done in a balanced way. So whilst I think a lot of people could argue that there is certainly really clear scenarios where other professions would have a case for being able to issue a fit note, this change and this move away from doctors for the first time since medical evidence existed had to be done in a balanced way that also took on board and recognized the unknown risks or the perceived risks on behalf of employers who have to cope with sickness absence and pay either statutory or occupational sick pay, but also the benefit system in the fact that fit notes give access to a journey that then leads to greater things. And part of that feeds into that picture of inactivity. So if it's done incorrectly and people end off for a long period of time, that's a very negative feedback loop that then makes it less likely they'll ever return to work in the first place. And this acts as a bit of a gateway to that whole process for both employers and the benefit system. So there was a lot of concern and reluctance, particularly cross government and from other government departments, in this change. And as such, and as part of the legislative process, we have to get cross-government agreement to lay and enact regulations. And so we had to do this as a kind of a cautious approach. And I think we do recognise that. But as part of the longer term strategy, this is very much seen as a first step. So these are the professions that were added this year. I think it's also worth highlighting that these regulations are enabling. So it doesn't mandate anyone within these professions to do the task or to issue fit notes. And that behind this, as with any clinical task, there should be an understanding position where professionals doing this have the necessary skills and training and be working in an appropriate role in an appropriate setting, and be able to evidence that where needed, to actually have work and health conversations in the first place, but then be in a position to actually offer advice and issue evidence to support that. We move on to the next slide. So what I partly want to loop this back to kind of close this bit off, is that one of the big driving forces behind this is, because there's a couple of elements to this. There's the side that supports employers and employed people and statutory sick pay and that kind of whole sick pay and absence management. There's the access to the benefit system. But at the core of this, what we were always trying to revisit was the patient perspective. So the fact that the policy intent that drives this is improving access to the right professionals who have the right expertise to have good, informed and supportive health and work conversations that then helps people to manage whatever it is they're dealing with and either take off the appropriate length of time that they need, or to stay in work and have adaptations put in place that enables them to actually not fall out of work in the first place. So from that perspective, the real drivers, especially through implementation, were to try and create continuity for patients. And one of the large parts of that was kind of along the lines of seeing the right person at the right time to get the right advice. And that would then avoid being basically pinged around the system where they're being seen by someone, which is what we anecdotally heard was happening previously, where they would get that advice, but in order to get the fit note signed, they'd basically have to be sent off to a doctor or a GP for that to happen. We are also aware that that does happen between systems, so between community, secondary and primary care, that for whatever reason, it could be access to the note itself. People get referred between those different parts of the system, having received care somewhere else, just for the purposes of getting the form signed. That means obviously that if we can sort that out, it happens quicker for people, so they get the advice and the evidence they need at the right time. But also means that if they're getting that from the right person, and it's not based on a conversation that someone else has had that then is being relayed, that it should reduce the errors within any kind of system, which is only ever helpful to the patients. But recognizing that underneath all of this, if we can do all those things right, it does also benefit people working within the healthcare system, the professionals themselves, because they avoid unnecessary appointments and things like that. So actually it is better for all involved. That's, I think, everything I was going to cover, and probably enough of my voice. So at this point, I am going to hand over to Abby for the next section of this.
Thanks very much, David. That's really, really helpful, really insightful. Thanks for sharing. Hi, everyone. I'm Abby Henderson. I'm Head of Practice Improvement here at the CSP. Great to see so many of you with us this afternoon. So David has given a great summary there of the legislative changes that have happened over the period of this year. And what I'm going to do is going to talk a little bit more about the implementation of it, some of the practicalities, talk a bit more about the training, etc. So really how we can support the implementation of this, because we do recognise it is a change. So just to be clear as well, that I am speaking for the CSP, but the professional networks who have kindly joined us this afternoon are also represented within these slides as well. So we're all in alignment with what I'm going to say this afternoon. So hopefully this is going to be helpful to you. So firstly, I thought it would be really useful to really cover why have physiotherapists been included. As David said, there were multiple professions that were looked at in terms of extending the legislation. I would just say that this has been a long-standing policy aim for the CSP. So many colleagues before me worked on trying to get this legislation extended. And I think that's in summary because we know what our profession can really offer in this space. So we worked really closely with the DWP and other partners involved to help deliver this change. and we collaborated and co-produced some multi-professional guidance that I'm going to talk about in a moment, and also the training. So I think it's important to understand that, so that you can be reassured that the guidance that we are linking to fully aligns with the CSP position as well. So why did we want to pursue this for so many years? And I think it really simply, we feel that physiotherapists are best placed and ideally placed in many contexts to support patients to return or to stay in work. And I think really note that I've purposefully not said ideally placed to sign the fit note. Exactly as David has said, we must be really clear that we view this change as a facilitator and an enabler to have more meaningful conversations with patients about work. And this does include patients with acute healthcare needs and those managing long-term, and also those managing longer-term conditions. And I think it's worth remembering that people don't need to be 100% well a lot of the time to stay in or return to work. But exactly as David has said, they require the right advice at the right time and support to be able to do so if that's the case. And why can we do this so well? Well, some physiotherapists, as you've seen from the poll, have specialist skills in this area in work and health, and they do a fantastic job in occupational health to support those patients. But this isn't required to certify fit notes. All physiotherapists have skills to assess the impact of health conditions on function and how to modify activities, and that's for the short and longer term. And that really, I feel, is a core skill of our profession. Planning to return to work is often a key part and focus of rehabilitation. And, you know, a graded return to work plan is very similar to applying progressive overload, just a different context. The therapeutic relationships that are shared between patients and physiotherapists in many contexts will facilitate these conversations. And that shared decision-making and goal-setting approach is absolutely integral within our profession. And work is going to feature in many of these conversations already. And just to be really clear, the majority of fit notes are currently issued in primary care, but this legislative change is not just for that context, and I'll touch on that a little bit later. But physiotherapists work with multiple, often large populations across diverse settings, and that context obviously includes primary care, but also other areas where we can have an impact. So I think you can see that the impact on population health could be really significant. And we've seen many extensions to our scope as physiotherapists over the years, including independent prescribing. And we at the CSP felt it was a really important area to ensure that we were represented in this space of work and health. So who should certify a fit note? So what I want to do here is really drill down what the legislation means for you, but then put that into a professional context. So there are two key questions really here. Can you and should you be issuing fit notes? So again, remembering the aim of using a fit note is to help support patients to stay in work and return to work as soon as is appropriate. So can you? The law is inclusive of the whole profession. So it means everyone across all contexts of all physiotherapists across the UK, because the legislation has been mirrored in Northern Ireland, with no restriction on setting or population. This is from the point of HCPC registration. So there is no statutory requirement to do further training or be at a certain level of practice, such as advanced practice. And all context and setting means exactly that. So this is not just for primary care, and we did not lobby for this change just for FCPs. It's important to consider the place of fit note certification across our profession, across our patient pathways, and across our populations. And I think you can see that represented by the number of professional network colleagues who have joined us today on the panel. Secondary care particularly is being encouraged to support primary care colleagues by issuing more fit notes as appropriate. And in secondary care, that can also include in clinics or following an inpatient stay for illness or surgery. Having said that, there are a lot of factors to consider about whether it's appropriate for you or your service to be involved with the certification of fit notes. And we're going to talk about a few of those today. And top of those is absolutely scope of practice. So you can see here the cornerstones of practice, which help you determine whether something is within scope or not. So the legislation has been covered by David very clearly. It's now in legislation. From a professional perspective, we are clear as the CSP that certifying fit notes is within the scope of our profession. So then it's the other two areas that are really up to you as individuals to explore. So, for example, in the workplace, you need to consider aspects such as your governance policies and your procedures. This is something new to implement. It's going to take time to establish this. And the feedback coming in is confirming that it's these procedures that are just taking a bit of time to develop. And while the earlier we implement this as physiotherapy profession, the earlier we'll start having an impact. It's obviously really important that it's done appropriately, considering all the aspects that are described in the guidance that I'm going to touch on, plus any additional local factors. And we'll touch on some of those in a moment. And then finally, the regulatory requirements. The HCPC were involved in this legislative reform, and the standards of proficiency are clear for all activities that all physiotherapists must be educated, trained and competent in all their activities that they undertake. And FitNote certification is no different to that. So to touch on the training and guidance that's required, both the HCPC and CSP were clear that before increasing your scope of practice, you should obviously ensure that any gaps in your knowledge, skills and experience are addressed with additional training or support as may be appropriate. And obviously that's going to look different for everybody. The learning needs of individual physiotherapists will look different. Those of you who have been issuing the AHP Health and Work Report, which has been around for some time now, you'll find the transition onto FitNotes really quite a simple process because you already have the skills around having those health and work conversations. So it's really up to you as an individual, as with anything else, to determine what steps you need to take before issuing FitNotes. But to support this, we have worked with other colleagues, professional bodies and stakeholders with the DWP to develop multi-professional guidance and an online training module. And May is going to put the links in the chat so you can link onto those more easily. So I'll just touch on the training module for now. This is housed on Health Education England's e-learning for health access platform. And it's divided into 4 aspects. There's a real emphasis on the value of health and work conversations, the relationships between health and work, and how the FitNote plays a role in these conversations. It covers a legal framework and legislation that we've talked about today, and it also really helps for you to understand what you need to know when carrying out a work and health conversation. The 3rd session covers the assessment of a person's ability to undertake tasks relevant to their work, and using the FitNote to make really practicable recommendations. And then the final session builds on all that information and uses a case study approach to help you support to put that into practice. And there is also an assessment at the end. It was developed, as I said, multi-professionally, and some of our members were involved in the development of the training as well. And the feedback has been really positive. There's a high rate of completion, and looking just today, the feedback is between sort of 4.3 and 4.4 out of 5 for each of those sections. So it seems to be landing really well. So obviously a lot of you have done this. If you haven't, that's exactly where you should start. We were clear as we were developing this that the training must be open access, and we did gain agreement that all physiotherapists from all UK countries and sectors should be able to complete it. So even though it is housed on HEE's e-learning for healthcare platform, everyone can access it, and this does include private practitioners. It is worth noting you still do need to register to get an account to gain access. And if you're struggling with that, there are some instructions on how to do that on our website. So as a minimum, we do expect as the CSP, physiotherapists to have read and followed the guidance, which I'm going to talk about in a moment, and completed this training before issuing FitNotes. But we recognise and we're hearing that this might not be sufficient for everybody, and we'd expect local training to be arranged to meet those individual needs. If you're working in primary care, do contact your local training hub because they may well be able to support you with additional training. In addition to the guidance, we've also developed some FAQs on our website, and there's a wealth of other guidance for healthcare professionals, which is appropriate for physiotherapists on the DWP website. And it's also just worth pointing members to the ACPOHE Learning Hub as well, which has some great free access resources as well, all about those health and work conversations. So what does the guidance say? So I just want to touch on a couple of points of the guidance. This is not a comprehensive discussion, so you really do need to read the guidance. I would say it's very digestible, it's not onerous or too long, and it does have some really useful FAQs in the back. So I'd really encourage you to have a look at it. It is for healthcare professionals themselves, and it's also for employers of healthcare professionals to help them identify who might be suitable for this task. So it provides a summary of the knowledge, skills, experience and training that healthcare professionals are expected to have before issuing fit notes, and touches on some of the governance things that I mentioned previously. I just want to pick out two elements of the guidance for a bit further discussion. So firstly, it talks about access to patient records, to patient medical records. And this will be a significant factor in your decision as to whether you have sufficient information to make a decision about a fit note. So this particularly will be the case for longer term conditions. So to be clear though, there is no red line that if you don't have access to the medical records, you can't certify. Certifying a fit note is a clinically reasoned decision. Knowing more about the history of that patient, including perhaps information about their work history, previous work absences, might be a necessary part of that clinical reasoning. But in certain situations, it won't be. So this is down to your clinical decision. Similarly, included in the guidance is around MDT working. So working in some areas, healthcare professions might be limited in their ability to connect with other members of the clinical team involved in the care. And that might be detrimental to your ability to make a judgment about fitness to work. But again, this comes down to your clinical decision-making, as with anything else that you do within the course of patient care. I specifically wanted to touch on private practitioners because I would say this is probably one of the biggest queries that we have had in. So bearing in mind what I have just said about this legislation is permissive for the whole of the profession, legally, private practitioners are able to certify fit notes in the same way that private medical doctors can. The same principles we've discussed around scope, training and implementation should be considered by private practitioners. And we'd recommend that all private practitioners ensure they can follow the areas considered in the guidance paper, and they may well need to pay particular attention around the access to appropriate information and the ability to liaise with others. So it's not envisaged that private practitioners will routinely issue fit notes. However, we recognise that pressures on primary care may mean more patients are presenting with conditions to private practitioners that necessitate a fit note than perhaps previously. And we shouldn't assume that these are patients who don't require access to benefits. So that option is available to private practitioners. However, only practitioners treating NHS patients are able to access either the digital fit note or the paper copies of the Med3. That's what it's called, the fit note, it's called the Med3. This is the same situation for medical practitioners and is a legal position. So there is nothing that we can do as a CSP to change that in terms of access. This is just the same for other private healthcare professionals as well. What you can do as a private practitioner is produce a report that includes all the information set out in the regulations. There's a little bit more detail on this on our website, but this is called a form to like effect. So we at the CSP, we recognise how useful a template it would be to have a template to follow. And we've been discussing this with Physio First as well. And the CSP currently is seeking legal advice as to whether we can provide that for you. There are a lot of legal complexities that I think David alluded to. So it's not something that's been done before in the private medical sector. So we're exploring this and we'll keep you updated through our private practice bulletin as well. In the meantime, the best thing we can do is advise you in your reports to make sure that you include all the information that's required on the Med3 form. Private practitioners should also be aware of the need to respond to DWP if they request further information as they consider eligibility for benefits. So it's really important to understand you can't be paid for this additional work, and you can't charge patients. Just to follow that through, what we should also consider, and this is private practitioners and the rest, and anyone working, any physiotherapist in any context, is to continue to consider issuing AHP health and work reports instead. The template for this remains on the website. This has not replaced the AHP health and work report. Provided the employer agrees, these reports can evidence eligibility for statutory sick pay. And it is suggested that these are widely accepted by employers. But this is the same situation for fit notes. For Med 3s are still only considered advice. They still have to be accepted by the employer, and that is the same for private medical practitioners as well. So we'd really encourage members to continue using the ACPOHE Health and Work Report, because while they're similar in content, they do allow more detail to be shared with the patient's employer on recommendations relating to work. But do remember, only the Med 3 fit note provides eligibility for benefits. So it depends on your patient context. And then I just wanted to summarise here that some of the practicalities. So the Med 3 forms, the fit note forms, are available electronically in some areas. There is an upgrade of NHS systems across primary care initially, happening to mean that that they are all becoming electronic, and that the wider healthcare professionals who now have access to certification in law are able to access those electronic systems, but it is taking some time. So paper pads are being used extensively, I would say, still in primary care. If you're in a different NHS context, you can order the paper pads as well. So you can order those as a physiotherapist if you are treating NHS patients. It's worth noting that physiotherapists working in the independent sector providing care to NHS patients are able to use the Med 3 pads, but only for those NHS patients. So when you're looking for further support, I would just advise you to share your learning as ever. There are a lot of services that are new to this. Obviously, everyone's new to this. Some are a bit further on than others. Please do share your learning. So look locally, speak to colleagues across different teams, see what's happening locally. If you can't access a GP mentor, or if you can't get support from your GP colleagues or your medical colleagues, do look for clinicians who perhaps are more familiar with the ACPOHE Health and Work Report, for example, because they will be able to provide you some support there. Look regionally at what other services are doing, tap into your networks, and then also obviously look nationally, look at the CSP resources, look at the professional network resources, ACPOHE particularly, as I've said before. And finally, just to summarise, remember that the law is permissive. So not every physiotherapist is automatically required to or expected to issue fit notes. As with all clinical activities, we should consider whoever is best placed to advise that patient about work and health. And we should use the fit note as a tool to support this. So this may well be you as a physiotherapist, but it may not be as well. This is not just influenced by your capability to do it. We've explored all the other contexts, some of the other contexts that you need to consider as well. But this is a great step forward for the profession. It's a real opportunity to support our patients to stay in and return to work wherever possible. And in that way, the impact on population health can be truly significant. Thanks very much.
Thank you very much, Abby. Excellent work. I'd like to invite all of the panelists now, if they want to turn their cameras on, so everybody can be seen while we get into the Q&A. I think that would be useful. Two great presentations. I think there are lots of great questions that have come in. I'd like to start near where you finished off there, Abby, and I think you did make the point, but I think it's worth reiterating. I'm going to direct this question to Paul, if that's okay, from ACPOHE. But if you want to just talk about maybe the difference between the ACPOHE Health and Work Report and what the benefits are to using a fit note or using the ACPOHE Health and Work Report would be useful.
Yeah, so I think Abby covered that really well, to be honest, but just to reiterate the same point. So the two reports are very similar in terms of where they stand legally. So they both have the same purpose in terms of they're both advisory, as Abby said. They advise on fitness for work, help us to provide a return to work plan for someone, or advise on modified duties. They can both be used for statutory sick pay as well. So exactly the same from that point of view. Sometimes employers aren't as familiar with the health and work report, and that might be a place where the fit note could come in. And I suppose the other legal difference is, as Abby said, that the fit note is the only one that can be used for claiming ill health benefits and universal credit. But the health and work report does offer more in terms of space for recommendations. So I think as long as the employer is happy to accept it, and unless you are claiming ill health benefits and universal credit, the health and work report is a great resource. So if you haven't seen it and used it, I can see the link's been put in the chat. Definitely recommend you have a look at that, because it kind of splits out the problems and the recommendations together and lays it out really nicely for both the person and their employer. So worth having a look.
Brilliant. Thank you very much, Paul. Really useful. The next question I think is for David, really, and it's a combination of questions, and it's around IT systems. So thank you to Carolyn, Lisa, and Charlotte, who've kind of asked a very similar question. Essentially, it's around how quickly or how well the electronic systems can be embedded within the electronic patient records within hospitals, and the kind of the risk of information governance that paper notes may carry. And I just wondered if you could speak to how that happens or already within general practice for GPs, for example, and what the timeline might be.
Sure. So if people are familiar with systems, hopefully they'll appreciate that the way it's coordinated is through the system suppliers. So we have to work through digital teams to get system suppliers to update their systems, which isn't always the easiest tasks. So we've done this for general practice. So across Great Britain, fit notes are accessible for those working in general practice with access to the systems, and they can have that full functionality. Northern Ireland aren't there yet, so it's not UK wide, and we're still talking to them, but they operate their legislation separately, so it works differently. In secondary care, I think someone did ask the question about mandating trusts, and we have effectively done that. So there was a new information standard published on the 10th of November, and we've been working, and this is within England, with NHS Digital, that basically sets out the timeline for them having to meet that requirement, so that there is parity between primary care and secondary care systems for access to the electronic version of the fit note. I think someone's already mentioned that several of the system suppliers have already flagged that they've been given till this point, basically next year, so November 2023 is the deadline for that. We are working to try and bring that forward, but that 12-month timescale is the normal contractual arrangement for suppliers in secondary care, so that's kind of out with our control. And the next step for us is community care, because I think I spotted a question around that as well. But the picture around system suppliers in community care is much more complex, so it's likely to take a bit longer. So we're basically dealing with them sequentially. We do recognise that System 1 operates across those, and we are working very closely with System 1 currently to explore what options are available to us, capturing it within the existing information governance. In terms of clerical, so the paper med 3s, essentially it's an extension of the position that's always been possible for doctors. So where system access isn't possible, either yourself or your organisation should be able to order those through gov.uk. And I think the criteria has been set out. You have to be treating NHS patients and delivering NHS services to those patients, and it's only for use with those patients, and that is very clear. I think it is worth flagging we have been aware of issues around ordering. With the way that print contract is delivered, it appears the supplier hasn't been able to readily recognise where some people who operate privately but are subcontracted to deliver NHS services to patients are doing so, and where it looks like a private business, they have been kind of following what is the criteria as they can see it, which we are still working to address. But essentially, as was the position previously for doctors, if you're using the paper forms, there is a process behind secure storage, but we don't audit them simply because as a clerical process, we can't, and we recognise that, and that entire process is run by government essentially at a level of risk. But from our perspective, I say risk, we are confident that professionals doing that are operating within their professional scope of practice and sphere. So whilst it's labelled as a kind of risk because we can't collect data and audit them, from our perspective, we would trust and hope that professionals are acting as we expect them to, so that whilst we don't see them or collect the numbers or have any data reported back, that's just the way it has to be, because the alternative would be no access to being able to use those Med3s. Ash, hope that covers everything. I think I saw a couple of questions pop in, but I want to give opportunity for other questions.
Yeah, no, really helpful, David. I think that's covered definitely the three that I had in mind. So thank you for that, and I'll direct more your way if they come in while I'm speaking. The next question, I want to move to talk about training, and I'm going to direct that on my screen to the middle row here, which is Michelle, Matt, and Laura, to start with around postgrad training. There's a question there about where should the training for this sit? We heard a little bit about training there. Is it postgrad? Is it pre-reg? And just your take and thoughts on that before I go to Paul as someone who implements pre-reg training already. So I don't know whether Michelle, Matt, or Laura want to go first.
From a post-grad perspective, Ash, I think it's really important that you're working within your local governance processes, because everyone will have their own governance arrangements around implementing this process, and that maybe differ from my organisation to Laura's organisation. So it's important that we look at our local procedures and we're following those pathways. You may well, certainly within a lot of advanced practice areas, we're suggesting that we can treat it a little bit like non-medical prescribing, in that you will have regular chats around these patients and discussions that then can go in your portfolio of advancing practice that show that you're having these conversations and you're working at that level and you're not just signing a piece of paper. I think that's what's really important. We've all learned today, and Abby talked quite a lot about the 4 different aspects of our professional conduct that we have to work towards, but I think it also comes into your local arrangements as well, and you've got to make sure that you're working within your scope of practice.
Brilliant. Do Matt and Laura want to add anything to that before I go to Paul?
I was going to come in on a question there about, I think Nick may have raised about PCNs being comfortable with FCPs, for example, in signing off patients with acute medical needs. And certainly there seems to be an appetite for that, because with first contact, naturally, we're seeing the patients who may benefit from that most. One of the interesting observations about the fit notes being completed by GPs is that when it comes to the ticking of the box of maybe fit for work, across the system, it appears that that's really grossly underutilized. And so there's a suggestion here that physiotherapists could be ideally placed for looking at that particular option, perhaps because they've got more time with patients. Which I think sounds fantastic. But the other move is that patients who are often coming to us with sort of various healthcare needs, the more vulnerable groups often don't have access to occupational health. And so there's a suggestion that FCPs could spearhead, depending on lots of factors, because we're so keen to get our teeth into everything, a primary care-driven occupational health setting, where we start to work across an MDT setting and feed into that and learn as well. And that might be of interest to start working with the PCNs outside your face-to-face work. And so you pick up on skills and the learning across the PCN. But it was really emphasizing that if we're starting to do this, that the option of maybe fit for work is currently underutilized across the system. And so that could be a real benefit for us in addressing that.
Brilliant. Thank you, Matt. And just because there are some great questions that I want to get to before we close in 5 minutes, Paul, can you just touch on pre-reg training there very quickly for me? Yeah,
that's fine. So absolutely, it can be introduced in pre-reg, and I'm now work at the University of Salford and have introduced it there. So we are already teaching it at pre-reg, very much an introductory kind of session to it, and then get practice using it at that stage. Don't think that's universal yet, but we'll be growing in undergrad programs. And final point on that, just to give a quick shameless plug, because I've seen Kathy's put it in the chat, one of my colleagues at ACPOHE, for postgrads. There is training available as well through APPO, which we've developed through the CSP, which is a workshop format. So do have a look at the link that Kathy's put there. Thanks.
Excellent. Thank you very much, Paul. This is probably going to be the final question before we wrap up. We may squeeze one more in, depending on the outcome. But there's a few questions in there that have been upvoted quite significantly around private practice, and a little bit of a sentiment that private practitioners are still feeling that they're not able to do what they should be able to do with this form and return to work. I wonder, Pam, if you could talk to some of those questions for us from a Physio First perspective, and just outline what your perspective is on private practitioners in this process.
Yeah, sure. I think first of all, I think I think private practices are beginning to consider this a lot more than they might have done, because the demographic of our patients has changed significantly post-pandemic. So I think certainly it's a concern that we possibly might not have had some years ago, and now it's forefront, and we've had a lot of inquiries from members. I think Abby answered in her slide particularly well. At the moment, there are barriers, and barriers that are understandable, but obviously things that we are trying to work through. So the access to the training is available. It is quite tortuous to register. You have got to wait for approval. But having gone through that process, it does work over several days, but don't expect to access the training and do it the same day. The access to full patient notes is a concern, because I think within scope of practice, that would be something you would need to defend really well if you were going to take the role of saying someone was fit to work or even not fit to work. The access to Med3 is a problem, and obviously the development of some sort of template that mirrors that could be available in private practice is something that we've talked to the CSP about for some time now, since the beginning of this process in the summer and the spring. So I think I do completely understand the barriers, but and maybe our members don't always completely fully understand those barriers, but there is the legal issue of the access to the patient note before the access to the Med3 form. So I think that we do need to talk to people about that. We need to try to help those in the independent sector, because there's been a couple of comments in the chat. We are very well placed in many aspects to do this, and to help the population to get back to work and help employers and GPs understand those things. I would agree completely with Paul and others. The AHP form possibly is not used in private practice as much as it could be, and therefore to encourage that as an initial route to make sure that everybody is doing that in the first instance, and helping the GPs therefore to fill the fit note in a bit more appropriately might be one way to go. So it is work in process. We are really interested in getting private practice involved in this, but fully accept from everybody else's point of view where those barriers might lie. So the answer, I suppose, is in scope of practice, access to notes, and let's see whether we can work on a template.
Brilliant. Thank you very much. And magically, we are almost exactly to time. I've got 1 minute to wrap up. I want to say thank you to the panelists and the speakers. I thought that was excellent. I think it gave us a really broad perspective of what the fit note can do, and what we're able to do now, and hopefully what we're able to do in the future. I think we need to hold on to some of those points that David made in his talk initially about how significant health and work is for the population, and how much of an influence we can absolutely have on that demographic of people in the population to make sure we're really contributing positively. Thank you very much, everyone. Have a great rest of the week. Merry Christmas for those, if I don't see you before then. I don't think it's too early to say that now, is it? No, but thank you very much. Merry Christmas, Happy New Year, everyone, and catch you all soon.